Hello, everyone. Thanks for joining us here at the STAR Center for an exciting afternoon webinar. It's the first of a three-part series on using our recruitment and retention plan template, now available for free for you on our website at chcworkforce.org. So this series is really about sharing the tool piece by piece. It's very comprehensive about building your recruitment retention plan, and so we want to just give you some additional support and some chance to ask some one-on-one questions about how to use it, what you might want to use it for, why certain parts of it are important, all of that stuff. So I'm just going to make a few housekeeping announcements here, and then we're going to get right into the meat of it. But you may be wondering, if this is your first time joining us, who I am. So my name is Allison Abe-Sekera. I am the Director of Training and Technical Assistance here at the Association of Clinicians for the Underserved. We are a national nonprofit that receives a national cooperative agreement from HRSA's Bureau of Primary Health Care to provide free resources, training, and assistance to you on clinician recruitment and retention. So HRSA and the Bureau, thank you very much for their support. They give us support here so we can develop all of these materials for you and provide them for free. And the project home for all of the stuff that I'm talking about is at chcworkforce.org. So you can go check that out. Get more information on the free resources available there and how to get some one-on-one assistance. So I'm joined today by our staff assistant, Mariah Blake. She is the person who keeps all the trains running on time here at the STAR Center, and she's the person that you're going to want to chat to, call, or email if you're having any real problems with today's webinar, or if you just want to get in touch afterwards to find out how to access all of the resources here. Her information is here on the screen along with mine, and she's also available through the chat function on the GoToWebinar software. We also have, for your viewing pleasure, and so you can follow along at home, some handouts listed in the handout section in the GoToWebinar screen on your right there. That has copies of all three parts and appendices of the Recruitment Retention Plan template. Those are also available for download on our website, but all of that's just here, so you can click it, download it now, and you can follow along if you'd like with the actual template as our guest speakers go through. We are recording today's session, so please be mindful of that, but we would love for you to ask questions. There's a questions box to your right as well as a chat box to your right. Feel free to put any of your questions in there. We will be answering those if applicable along the way, but mostly we'll be saving those for the end of our presentation today. We're scheduled to go to 3 p.m. Eastern. So get comfortable, my friends. We have a lot of excitement here for you, and we're so glad you joined us. Our presenters today are both from John Snow, Inc. They are a partner organization of ours on all of our projects. And Paddy DiPadova and Pamela Burns are both fun and extremely knowledgeable. So they're going to be helping us go along through today's Recruitment Retention Plan template. They're the ones that put it together. They have lots of exciting, relevant information to share with us today. So with that, I will turn it over to Paddy.
Thanks, Allison. Can everyone hear me?
Yep.
We can hear you.
Okay, great. So I'll just make sure that I have the ability to change slides. Not yet. So Allison, if you don't mind scrolling through the slides for me right now. Okay, thank you. So again, as Allison said, this particular webinar is on just the very first part. There are 3 main parts to the recruitment and retention, or retention and recruitment plan. And part 1 is practice assessment. It's pretty meaty, so we also would again like you to look through your plan template after this is over. Feel free to email me or anyone at the STAR Center with any questions that you have, and you can move to the next slide. So the main purpose of developing this plan, this is the written purpose that is up here, is to basically provide a structure and a thought process for improving retention and recruitment practices. But one thing we did when we were starting with the STAR Center resources, we were looking obviously for resources that already existed, and everything that we could find said everybody really needs to have a written recruitment and retention plan, but we really couldn't find any good templates for that. There were some, but they might have just been a one-page list of the things you need to do to recruit. And there's a lot out in the literature and in our experience as a group that we know that's important, not only for recruitment, but for retention. And so we developed this plan, and I'll get into that a little bit further. Next slide. We developed this plan to make it easy for you to develop your own structure. You can kind of pick and choose through elements in the plan, but we would advise kind of going through everything with a recruitment team just to ensure you haven't missed anything. So the main part that we developed were the instructions, which you see there on your left, the actual template, and then the action plan is the third part. Next slide. So the instructions are it actually has the template incorporated in it. The reason we have a separate template is so that you don't have to kind of delete all the instructions in between, just to make it a cleaner document for you. But the instructions are really the full template, plus all the rationale for each element that's included in the template, the things to think about. There's some benchmark data included in the instructions that you may or may not choose to use in your own plan. And there are some examples so that it gives you a better idea about how we meant to use each of the tools or the tables that we put in there if there's any confusion on how to use them. Next slide. So this template is something that you can save. As we said, you can download it. It's in Microsoft Word intentionally. We wanted it very easy for you to use. And there's also an associated Excel tracking form because there's one table that we thought was critical, but it's very big. And it's basically the table that you would use to track candidates through the actual recruitment process. Next slide. I think I have control now. So we've also incorporated this action plan. It actually would be a good thing if you have downloaded it to kind of go through with us. The action plan lists the topics for each of the three main parts. And the main parts are the assessment, recruitment, and retention, and then recruitment. And it keeps track as you're going through making your plan of the places where you found that you have gaps. So we may have a table, for example, that has you record what types of advertising you're doing in social media, and you might be like, oh, we're not doing any. So rather than spending a lot of time on that while you're making your plan, you would put that over into your action plan as something on your to-do list. Or something for your team to meet about to decide how you want to tackle it. The action plan also helps you identify strategies, so you have things on your to-do list, and then it will give you an area to kind of talk about and then document the strategies you want to take for improvement. And it also has a column for the timeline that you want to complete things by to give you kind of, you don't want this plan to be something you just put up on the shelf. It should be a working, active, living document. So you need timelines, you need to know who's responsible for doing things, and the action plan is where you can incorporate some of those things. So as I said, there are three main sections of the tool. The assessment is what we're going to be focusing on today. The second part is the retention plan, and we put that second, even though people may choose recruitment because it would go in that order. We think retention is actually far more important than recruitment, because if you can retain the providers that you have, you won't necessarily need to recruit new providers unless you're growing. So we put that focus in those terms. So why would we want to conduct a practice assessment, and why is it included in a recruitment and retention tool? It's really critical to take a look at the things in your practice that might be impeding your retention and recruitment processes. In addition, it's just a great idea to have a really good understanding of your practice. You may already do practice assessments, and they clearly can be broader than what we're going to focus on today. But it's we've chosen the things that we think can impact recruitment and retention the most. I'm not going to go over every single little thing you need to fill out in the template. You can look at that yourself. Some of it are, there are dates for when you've last done a plan, dates for when you may have updated your provider compensation, those kinds of things. I'm going to be hitting on the larger tools and the main concepts of what is in the retention and recruitment plan, and I will be doing that practice assessment as well. So you want to, again, have a better understanding of your practice. You need to identify issues that can be impacting this kind of laundry list of efficiency, quality, barriers to care, access, provider and support staff satisfaction and retention. And support staff are included in there because clearly support staff support to providers is critical for retaining providers and for recruiting providers. Patient satisfaction, use of resources. You don't want to be spending more than you have to make everybody happy. You have to live within your budget. So it's kind of including all of those things. And then developing the improvement plan and strategies that we've already discussed, and reviewing and modifying your recruitment and retention strategies in concert with that improvement plan. I'm going through this slide up, the model for improvement, because it's really important to note that this retention and recruitment plan fits in very well with the Institute for Healthcare Improvement's model for improvement. So you've probably heard of the PDSA cycles. Let me do that little spin there, but which is plan, do, study, act. And we're going to be focusing on the planning stage with the retention and recruitment plan. The action plan addendum that's included with this it moves you towards the do. And then the data that's included in the retention and recruitment plan that you will have hopefully collected and put into your plan contributes to studying the impacts that you may have had by any of the changes that you've made, future actions again, and then back to the planning stage. So the planning stage for this particular template would be collecting the data, and there are a lot of data points we'd like you to take a look at in the assessment in particular. Comparing whenever possible to benchmarks or to policies that you've put in place or to guidelines that might exist. Identifying reasons for the differences or the root causes, and we're going to help you with that. We have some grids to help you identify what some of your root causes might be for issues that you may have. And then again, developing the action plan. This is what the action plan looks like. This is the assessment page. It's very brief, simple. Again, it's in Word, so you can just easily put things in here. So the topics are on the left side, and then it's identifying the gaps and barriers that you again, go back to the social media, maybe, and that's probably an example for this one since we're on the assessment. But potentially you found a barrier for appointment access. You don't have enough hours to meet the demand. So then you take a look at what opportunities you might have, what strategies you might have for improvement, and then a timeline that you'd like to complete that by. It would also, again, be a good idea in your strategies to make sure you have a person responsible. For the retention and recruitment plan assessment and the operational assessment and strategic planning, these are the main areas we're going to be taking a look at. We're going to take a look at provider capacity and demand, employment access, care teams and provider mix, the non-provider support staff, provider schedule, provider satisfaction, and provider succession planning. So productivity, I know people are talking about, payment methods are changing. Productivity is less important because more care will be done in other ways or is being paid for in a different way. Even that, with that being the case, productivity is still the predominant measure of patient care. Most of your patients are being paid on some sort of fee-for-service basis. There may be some pay for performance. There may be all kinds of things coming, and we know there's a lot of stuff coming down the pipe that may change that. But at this point in time, it's a very stable indicator to give us an idea about how many patients are coming in and the demands that are being put on providers and support staff. It's also a pretty good indicator of financial stability, how patient access can be impacted, and provider and support staff satisfaction. And I just want to note there that both low and high provider productivity can impact provider and support staff satisfaction. With low productivity can be a burden to the practice if there may be one provider that has very low productivity, which is pushing all of the patients to other providers. Or if it's low productivity for everyone, there could be a sense of boredom, inefficiency. So that can be a concern. High provider productivity really can be an issue if it's too high and providers are getting burnt out. So those are very specific reasons to be looking at productivity in terms of retention and recruitment. We've put this tool in the plan to just give you, if you don't already measure productivity, to give you some kind of structure for an easy way to pull it all together. This one's fairly simplified. If you have many sites, you would want to do a table for each site. If you have many specialties within a site, you may want to do a table for each specialty. This has specialty listed as the third column in. But if you have a very large health center with large numbers of providers, and I'm not saying specialty as in a surgical specialty. I mean, pediatrics, internal medicine, family practice, if you work in that way. If you have provider teams that are multi-specialty, you may want to do it by a team. This would be up to you. You can edit that in any way you like. But you want it to be done at a provider level, and then you want it to be able to be rolled up to a team, to a specialty, to a site, and then to your entire organization. So you can drill down to the data whenever you need to, but you have an easy kind of dashboard at the end of where your organization is in terms of productivity. So this particular table has a provider name and a provider type, and that would be whether they're an MD, DO, NP, PA. And the reason you need that information is because the benchmark may be different depending on whether it's a physician or non-physician provider. This is not where you would put nurses or like an RN or an LPN or medical assistant. These are people who can independently practice and bill for their time. So a nurse practitioner, a PA, a certified nurse midwife, a physician, DO or MD, this is where you would put that information. And then there's specialty, again, so you can roll it up. If one particular specialty is seeing a lot of productivity and the others aren't, you want to be able to identify that. so that you can pinpoint better if you need to recruit a new person. Their FTEs, their number of health center visits, and then the next one is a calculation of visits per FTE, and then we have suggested that a benchmark of the UDS mean visits per 1.0 FTE be used, and we provided as an appendix in the instructions, not in the template, but in the instructions. They're from the 2014 UDS. The 2015 measures will be out shortly, if not already, so we can update those as soon as we have permission to use those. And then you would calculate the difference from the mean to see where you are. Then what do you do with that information? You want to do a little bit further analysis. So you'd again have the provider name down the side, their type, and their specialty, and then take their difference from the mean. And these are the ones that you would look at, presumably for people who are far from the mean. So this table would not include everyone that was on the prior table, but it might include people who are 10% off either way in terms of their percent difference from the mean. You could suggest a different number. It would be up to you to determine. I would suggest 10% to start with, but maybe there's a lot of variability and you would want to do 25%. But then you take a look at, okay, with your team, what are the reasons that are possible for this particular provider to have either really low or really high productivity? And to kind of think those through together, maybe it's an unpopular provider or a popular provider. Maybe it's a provider who, for internal medicine, sees all of the HIV patients and they take more time, so you're not so worried about that. So there can be all kinds of reasons, and as a team you would sit down and discuss those and indicate what the reasons are. Another way to look at this is this grid, which is productivity on the left-hand side with low and high, and then on the top, possible causes, but possible consequences too. So for the low productivity, the causes could be a new provider. They're in their first year of practice or their first year at your health center. It could also be that you have one provider travel into 3 or 4 clinic sites and they lose time due to travel. So that's either something that is fine for you because you need that to be done, or something you might take a look at. Differences in on-call coverage distribution among providers. Maybe one provider isn't in the office as much to take more calls. Scheduling issues, and we're going to talk about that in depth as we get to the scheduling section. Staffing issues, again, we're going to talk about that more, but if you don't have enough support staff, maybe the provider is bringing in their own patients sometimes, maybe they're having to turn over their exam rooms, so that would clearly give them low productivity. Inefficient use of space, and we're going to talk about that a little further. It could be just a provider who's slow. It could be someone who has low patient demand because they're not popular, or their specialty is one that's not as in high demand as other things in your practice. Or it could just be you have maybe too many providers, and that oftentimes that can be okay, and that would be excess capacity. That might be okay because you may be a new center and you need a certain number of providers to stay open, so that you may have excess capacity because you're building your practice. Or you may have just hired in someone new. Maybe you needed somebody half-time, there was somebody full-time available, and you hired them anyway with the idea you'd grow your practice. So if those are business decisions, that's fine. But some of the possible consequences for low productivity could be reduced patient access. So if you don't have excess capacity, but you have a provider that's just kind of slow, or doesn't have much time available for in-office care, they have a large on-call demand, patients might not be able to get in. You could also have unfair labor distribution, that higher producing providers are seeing most of the patients. You could have boredom or dissatisfaction for those providers who are experiencing excess capacity, that there's just too many providers, reduce revenue, and it's clearly a less efficient use of resources. Again, that might be your business plan because of growth. So you really need your team to sit down and talk through all these things. For high productivity, you could just be a very experienced provider who's worked in the area for a while. It could be due to extended clinic hours. Somebody has a schedule that patients really prefer. There could be, again, the differences in on-call coverage, someone who doesn't take call. Scheduling, we'll talk about again, it could be someone who has a very fast pace and someone who's very popular and high patient demand. So consequences, I mean, clearly this sounds like it would be great, but sometimes it's not. It could result in a provider who's overworked, the unfair labor distribution again. There could be provider burnout, staff stress. If the support staff are trying to move quickly with its provider, it might be difficult. And it could also be due to a provider vacancy. So appointment access is the next area we would look at. It's very closely linked to productivity, as we mentioned before. Some of the issues of productivity may be access related. But appointment access provides key information on how easily patients can get in for an appointment. So this is if they call, how far away is it before they get in for an appointment. It's important for determining recruitment needs. It's also a patient-centered medical home measure, the third next available appointment, which is the measure we're going to propose that you use. So you may be using it already, or you may, if you are not already a patient-centered medical home, it might be something you would want to put in place if you have plans to become a patient-centered medical home in the future. It's also important to develop policies based on clinical norms. So, for example, just 3 categories that I've thrown out are for sick visits, follow-up visits, physicals. You could also throw in a new patient appointment, which would be like a physical for a new patient. And you should develop policies that give you guidelines in advance of actually even measuring appointment access. You need guidelines for what you think access should be. So, for example, if someone calls in that they're sick, depending, again, on exactly what they're sick with, you should be able to fit them in within a day or two, depending on what their particular problem is. For follow-up visits, you should be able to fit them in within a week of when they need their follow-up appointment, maybe 2 weeks. For physicals, you might want to be able to get people in 2 to 4 weeks, maybe 4 to 6. This is something that is dependent on your organization to determine clearly with clinical input. Your providers need to be able to give input on what is safe. You don't want to put in guidelines that are not safe for patient care. But you need to establish what those guidelines are, because measuring appointment access without having some guidelines to stay within doesn't really mean much. It doesn't mean much if somebody can't get in for 3 days for 6 appointments if you haven't established a guideline for that. And then this tool is to help you measure appointment access. I would suggest that you measure it once a week because it can change dramatically, and it is important to know what access is on a weekly basis. If you have someone on vacation, for example, you may have to do some things to your schedule to make sure people can get in and still meet your sick appointment access. You might push your physical appointment access out a little bit and have a 4 to 6 week wait instead of a 2 to 4 in the event that you have people away or someone else sick. So you would have those guidelines in place, and then weekly you would take a look at this. And we are again looking at it by specialty, but you could do it by team. And then you have the provider name, their type, and then the appointment type. I put those 3 in there. You could have more appointment types. you can modify this to any types of appointments that you like, and you may want to abbreviate it to what you use in your schedule. And then you would measure the third next available appointment. And the rationale with measuring the third next available appointment instead of the first next available appointment is because the first next available appointment isn't going to be very reliable. If you actually have a 6-week wait to get in to see a provider, but somebody canceled tomorrow, and you're like, oh, we have an appointment tomorrow, that's not really a good measure of what your actual access is. So the third next available appointment gives you a more reliable measure of what the actual date is that someone would get in. For example, if they couldn't take the first one either, if you have one available in a week, but if they can't do that appointment, you need to be looking at having choices for the patients, but also that you're not keeping the data because of cancellation or a last-minute opening of a schedule due to a provider canceling a meeting or something. It takes the variability out and makes it more accurate. So under third next available appointment, there's a spot for the date so that you can just put the date in, and later on you can do the calculations if you want to. And then you would calculate how many days from, and you need to write in the date that you're doing this measure as well, but how many days was that for a provider? How many days was it for their care team or their whole specialty? And then the column of whether it meets your written policy or not. So those are the guidelines we discussed in the prior slide. And if it doesn't meet the written policy, what are you going to do right now to fix it? So this reason or corrective plan isn't so much for your action plan. This is for you to take action on right away. You should include it in your action plan if you're seeing consistent problems with individual providers. One provider is becoming very, very busy and consistently has long waits to get in. One provider, nobody wants to come to see them anymore. So it really gives you a lot of information about what's going on a week-to-week basis with providers. And then for the bigger analysis, not the week-to-week one, but maybe more on a monthly or annual basis or quarterly, taking a look at, okay, we have providers with clear appointment access issues. So for those particular providers, not the whole laundry list, but just the ones that you pull out, and again, you might be 10% below or 10% above the average for productivity, and whether or not their access is within policy limits, you can do an appointment access analysis related to productivity. So if, and we'll look at the causes on the next page, but you can have people who have low access and high productivity, but you can also have high access and high productivity. There can be lots of different combinations. And so then you identify whether or not you have a capacity gap. Or you may have another non-capacity gap. So there's some kind of thing that is going on that either you don't have enough capacity or there's something else happening with your provider team or your support staff provider team that's impacting access. This explains it a little bit better. So this graph shows the box in the upper left-hand corner is low productivity with low access. And low access in this case is a long wait to get in for an appointment. And then we have low-high, which is low productivity with a short wait for an appointment. And then you'll see the high productivity with low access and high productivity with high access. So I'm going to walk through this because access is near and dear to my heart. It's one of the main reasons that health centers exist is to really increase access to the patients that need it. And if we're not meeting that, if we're not really working within our mission, if we're not increasing access to people, excuse me. And it really can impact recruitment. And it also impacts your decision-making process, or it should, for whether or not you should recruit. So in terms of looking at the low productivity, low appointment access box, the situation in this case is a provider with available capacity but unable to meet demand. So this is somebody who doesn't see a lot of patients, but they have a long wait to get in to see them. So some of the reasons could be a new or slow provider. Their office hours are being used for other activities such as administration or quality improvement. Their office hours are not reflecting their contracted hours, which I see very frequently. I do a lot of practice assessments. And that can frequently be the case, that someone's been hired in, for example, for 32 office hours a week, and over time that erodes. Instead of starting at 8:30, they now start at 9. Instead of their last patient being at 4:45, it's now at 4. So again, that goes into scheduling, which we'll discuss a little bit more, but that's a very frequent place for that to happen. And often it's not something that's been done to try to subvert anyone. It just erodes over time. Limited examiner space can be a cause, and limited support staff. So the action would be identify the reason for the low access and target with an action plan. So this is where you would hit on the action plan. So if you have a provider with high productivity but low access, so high productivity and a really long wait to get in for an appointment, it's an efficient provider with very high patient demand. So some of the reasons could be that you're understaffed due to a vacancy, or you've had an increase in patient demand. The action in this case is you probably have need more capacity to meet patient demand. So you can look at whether this is a temporary situation or not. Somebody might be on vacation. If it's not temporary, one thing that's not indicated here, but you should look at it if all of the providers are in this situation, then you probably need to recruit. But you might also want to review your team-based care structure. There may be ways to shift some of the patients to a team rather than this particular provider taking care of all of them. But it could also be a provider who's having to pick up the slack for a low-producing provider. So that isn't indicated on there, but it needs to be. So to look at the other boxes, if you have low productivity with high access, so this is someone who isn't seeing many patients, but it's a really short wait to get in to see them. That's somebody with low provider demand. So again, it's a new provider who could benefit from marketing their practice or working in an established provider team to help build their practice. It could also be an unpopular provider. So the action, again, is to try to figure out why they have low demand. Why aren't people trying to come in to see them? For high productivity and high appointment access, that's kind of what everybody wants. That's the golden situation. We have an efficient provider who's meeting patient demand. So it's a well-functioning practice, and it's a very efficient provider. People don't have to wait to get in to see this provider. And this provider is seeing lots of people, so it's perfect. But you do really need to think about it, though, because if this provider is experiencing stress in order to keep that situation in place, you should review the schedule and maybe see if you should lengthen the wait for appointments within clinic standards. You should also take a look at recruitment in the long-term plan in case demand increases. But that is the situation you want to be in as a very productive provider that has short waits to get in. So now pulling it all together and seeing how it impacts recruitment. Again, I have a little grid here. So for the situation with low productivity and a long wait for an appointment, that provider's available capacity but is unable to meet demand. The action, again, is to identify the capacity issues and resolve prior to a recruitment decision. For high productivity and a long wait for an appointment, if an efficient provider with high patient demand, more capacity is needed to meet patient demand, you may recruit or review team-based care structure. For low productivity and high appointment access, low provider demand, review the low demand causes. If it's a new provider, market practice. If it's an established provider in an otherwise busy practice, identify and resolve the issues prior to a recruitment decision. If it's neither, it is unlikely a need to recruit. You have capacity there, you shouldn't be recruiting in that specialty anyway. And then for high productivity and high appointment access, plan for future recruitment. That one is an efficient provider meeting patient demand. Again, if the provider is experiencing stress, you might need to recruit. So just that's kind of where we would put people in terms of, for the low productivity, it's pretty much unlikely a need to recruit. For high productivity and low appointment access, there is a need to recruit. And then for high, you need to just plan and keep a watch. So now the next part of the retention recruitment plan is taking a look at care teams and provider access. So interprofessional teams have been shown in the literature to be a really strong health center model. They help promote provider retention and recruitment, and they're fundamental to a patient-centered medical home. A review of the provider mix, which is the ratio of physicians to non-physician providers, can provide insight into potential problems and solutions relative to recruitment and retention. Non-physician providers, such as nurse practitioners, physician assistants, certified nurse midwives, can play a critical role in meeting patient demand and providing high-quality care in health centers. If your plan is to recruit a physician, you should really do this review to compare your health center with common practices at other health centers and other types of practices. In fact, you may benefit from considering recruiting a non-physician provider instead of a physician. There are a lot of benefits to this. Non-physician providers are in high demand, but are generally easier to recruit than physicians, and often can do nearly the same type of office-based practice that a physician can do. So this is important to just get a kind of feel for how you compare to others in terms of your mix. It's a pretty simple chart. And in this case, we've mostly given you benchmarks. Again, they're the 2014 benchmarks because that's the most recent data that we have available to us. But we've actually, if you have your UDF tables available to you, which you should, if you don't, you should contact UDF Helpline and ask them to send it to you. What we're looking at is your line 8 divided by line 10A from your UDF table 5. And that's the number you would put in under your health center, the green box that's on the screen. And then you just take a look at how do you compare to others. We put the UDF in there for 2014, and the ratio of non-physician providers to physicians for UDF 2014 is 0.81. So for every one physician provider, there are 0.81 non-physician providers. And that's the roll-up for the whole country. And it could be different by state, and if you don't have that information, it should be available on the UDF website. And if it's not, we'd be happy to help you, or the UDF helpline could help you, get that information by your state level if you prefer. The other numbers we thought you might want to take a look at in large part because we can pull it out by type of practice, is the MGMA, Medical Group Management Association data. If you're not familiar with that data, it's another national survey of a lot of indicators and practices. It does include many, many health centers. I think 25% or 30%, I have to look that up to know, hold me to it, but a fairly high percentage of all of the practices reporting are health centers. But it also includes all private practices, academic practices. It gives you an idea of what a lot of practices are doing throughout the country and what their ratio of non-physician providers to physicians is. And for the MGMA mean per 1.0 physician FTE, for family practice, they have slightly more than one non-physician provider to physician. In internal medicine, they have about 0.49, or about half of a non-physician provider to physician. And in pediatrics, it's 0.41. So just to give you an idea, I mean, you don't need to be on these numbers. These numbers may be right or wrong. They're just a benchmark to see where you compare. But if you're below any of these numbers, you certainly should be thinking about, rather than recruiting for a physician to your next position, if it's possible to recruit for a non-physician provider. So the next area we're going to move on to are the non-provider support staff. So this would be RNs, nurse practitioners, medical assistants, and really anyone that patients come in contact to. So it could be people who schedule appointments, it could be people who check people. But it's not the billing staff. It's not the administrative staff. So these are the people that patients come in contact with. So you need a reasonable ratio of well-trained support staff to providers. It definitely eases provider workload, particularly as we're now in an electronic health record environment. Providers are more and more reliant on support staff to assist them with improving patient flow. It also improves provider efficiency if they can give some tasks to other staff who can work within their licensure. And it improves provider and support staff satisfaction. Staff are, if they're not bored and they're able to be challenged in their job, support staff are more likely to stay at a practice, which frees up more time for providers to do the more difficult things rather than just them being the ones to do the blood pressures, et cetera. So it can improve retention everywhere. So if you have a high ratio, however, of non-provider support staff to providers, which can often be the case, it's an inefficient use of resources. So you have to be careful. There is a balance, and you don't want to have so many support staff that people are standing around, because then you could have been using your resources in other ways to reach more patients or provide more services. So for this one, again, we made it easy for you. I think I took the line off here on the UDS table, but it's in the, it should be in the retention and recruitment plan. You can just look on your UDS table, and in the green column for your health center, just put in what the staffing would be. Again, it's divided by the number of providers, so how many nurses you have divided by providers, how many other medical personnel, which is where medical assistants, nurses' aides, et cetera, would be, and then other patient support staff, so front desk, appointment staff, all of those functions. Again, this would not be your billing staff or your administrative staff. And then we've given you the benchmark. The UDS benchmark first, and then a column to compare your numbers to the UDS numbers. And then the Medical Group Management Association need per provider FTE by family practice, internal medicine, and pediatrics. And again, a comparison spot for how you compare to MGMA. Now, what our hope is that you'll take a look at this and see, if you fall well below or well above, that you pull your team together, and this is something that would end up on your action plan, is either to review whether you have enough staff or whether you have too many staff that maybe you could redistribute doing other things, or have some kind of a plan to not hire as many in the future. But this would be the data that you could use to help make some of those decisions. So we're going to move on to provider schedules. I love this area. A lot of people might not. It's really in the nitty-gritty. We're going to do kind of a high-level look to some extent, but we're going to propose that you do a very detailed look. So provider schedules are in the end what drives productivity and access. They can be impacted by having enough support staff, having enough exam rooms. And we're going to talk about exam rooms a little bit further, but the number of exam rooms you have available, the pattern of provider scheduling by day and by week, and it can also be impacted by the on-call schedule. One thing I haven't noted here, but I found in a number of practice assessments that I've done at health centers, is it can also be impacted by providers, again, protecting their schedules or eroding their schedules. So starting a little bit later, ending a little earlier, or lunchtime getting moved a little bit. But also the protection piece by providers saying you can't book anything in these certain hours can impact productivity and access. So it's important to be looking at all of those things. This is a true table that I pulled together from, and it
Excuse
is
me, Patty.
Yes?
I'm sorry, this is Pamela. I was going to say something, but I realized I was muted. That was just one of my really favorite things that you just touched on. And I always think a really good indication of how scheduling is going is how many little yellow sticky pad notes are attached to schedulers' monitors.
Yeah.
It's often an indication that there's way too much encroachment going on to the logic of a scheduling system.
Exactly.
Yeah, just what I'd mentioned.
Yeah. Thank you for that.
And I love this graph, by the way.
I really do.
I do.
There was I was hired to come in and take a look at a very large health center that has 10 sites and had a really large residency program. And they were having some horrible issues with scheduling. So what I did was take a sample week. I picked through a bunch, and I went through them with the appointment people, and I said, what is like the norm? I don't want one where there are lots of people on vacation. I don't want one that, has a lot of variability in it. That wouldn't normally happen. So they helped me pick a sample week. And then each of these lines is a provider. And you can see, each of these lines is the number of providers. If you look along the left-hand side, it's the number of providers. And then at the bottom is the day of the week and the time of the day. And you can see they had a Saturday clinic, and you can see they only had one person working consistently on that Saturday, all across the time period when they were open from 9:30 to 1:20 p.m. And then on Mondays, you can see they started with 6 providers. They peaked at 13 providers on Monday morning. And at 1:21 p.m., they have 14 providers. And then around 5, they would go back down to 1. And so you can kind of get a rhythm for, if you look on Mondays, you can see how people were starting to drop off. Their schedules, they were dropping off. But I think the most important thing to look at is the comparison of Wednesday afternoons at 1:20 p.m. with 18 providers compared to the peak on Friday afternoons of 9 providers. And of course, across this entire week, they have the same number of support staff. They don't change the number of support staff they have by the day of the week. It's constant. And they have the same number of exam rooms because it's a building and that's not going to change. So the stress on the support staff on Wednesdays and Tuesdays, actually, Monday, Tuesday, Wednesdays, was actually quite incredible because they didn't have more people to help these providers, and they didn't have more exam rooms. So they had people like milling all about and no place to put them, and providers getting upset, blaming the support staff, and really it was a scheduling issue.
Patty, this is Allison. Just wanted to let you know that we have just a few minutes left.
Oh, okay, I'm sorry. So anyway, this is an asset matching table to just take a look at the number of providers that are in on a given day, how many support staff are in, and how many rooms are available to kind of take a look at quickly trying to match your assets and changing your schedule to support them. I'm almost done. The other parts of the assessment are to take a look at provider satisfaction. These are the main reasons for provider dissatisfaction: staffing, workload, management, financial considerations, and scheduling and vacation, so inflexible schedules, lack of work-life balance. And so the template goes through some of the things that would be helpful in measuring and promoting provider satisfaction. So having satisfaction surveys, regular evaluation meetings, exit interviews, and social gatherings. Provider succession is critical. It can occur from retirement or changes in FTE due to changes in family or people who are slowly approaching retirement. And we have a table in there for you to take a look at, planning for succession and checking in with providers on a regular basis to see what their plans are and whether or not they may have changed. And then it's kind of just this wrap up, and then I'll stop talking. These kind of gone through practice assessments, and the next steps that we're going to be looking at are, if you look at complete retention and recruitment plan, our next webinars are going to be focused on retention, and then recruitment, and developing action plans. I'm going to turn it back to you, Allison.
Thank you very much, Patty. Thank you so much for that. That was really great and comprehensive. You know, I know for those on the line, depending on what your role at the health center may be, this may be something, this kind of planning, strategic planning for your staffing is not something that necessarily you've engaged with as part of, you know, your duties recruiting providers. But we really think, you know, that going through this whole process at the beginning is going to really help you save time and money on those recruitment activities, so you can really come up with a better strategic plan at your health center about how are we staffing, all the things that Patty's talking about, assessing your practice. How do you really build your site and your organization so that it's maximizing all the people that you do have, making the best use of your team, and building systems so that they're ready for the right new people to come in. You know, it's all about finding the right fit in terms of both the position type and the person who's going to be coming into your organization. So, you know, just would love, Patty, your thoughts as we look forward to the future about if this is something that's brand new for a person on the webinar, who at their health center, what kinds of people should they be talking to kind of collect all of this data and fill in this part of the template?
Well, typically it would be a team. It depends on, you know, the productivity information should be readily available to the administration. The access data, I would typically have somebody, you may actually, and I should have mentioned this earlier, with the access data, your electronic health record may have a report already in it that might be able to generate that report for you. So I would just validate it to make sure it's actually measuring what you want, but printing those reports out on a weekly basis or having your appointment staff actually do the reports, and making sure they understand what a third next available appointment is, so you're actually getting the measure that you want. But for most of this, you want to have a team working on it. And for the assessment, it's mainly administration and appointment scheduling, and whoever scheduled the exam room. But you want some clinical input on the guidelines for access, and it would be good to have a team with some fairly broad representation working on it, so that no stone is left unturned in terms of coming up with reasons that you may be different from what you would expect to be.
Excellent. Well, thank you so much, Patty. I think for everybody on the line, we hope that you got a lot out of this today, and at least a lot of brand new ideas about things you can consider as you're trying to figure out how to maybe solve some of your recruitment and retention problems. That all the materials for this are available in the handouts. You'll also be receiving the slides and today's recording via email. And we are available for free phone assistance at any time to help you talk through these specific issues and talk through even just this template. If you want to talk to Patty or Pamela or someone here about how do I answer some of these questions, or who should I really talk to on my team, and how do we have that conversation, we are here for you. So thank you so much for joining us today. Please stay in touch, and please join us for the next webinar in November, and we will talk to you all soon.
Thank you.